The major chemical associated with the trigeminal system that's involved with headache is something called calcitonin gene-related peptide. This shows the structure of that chemical. It becomes very important in the treatment of migraine. There's emerging research that suggests that calcitonin gene-related peptide is a promising target for the relief of headaches, including migraine. There are a lot of drugs in the pipeline currently in various stages of development that are designed to reduce the concentration of or the effectiveness of calcitonin gene-related peptide in this trigeminal system of the headache circuit. Thus, calcitonin gene-related peptide, and particularly methods that can reduce its expression, are very promising targets for the treatment of head pain.
All right, let's dive into the fascinating topic of the transient receptor potential A1 or TRPA1 for short. This unique receptor of neurons plays a crucial role in altering their excitability. We'll explore how the TRPA1 receptor is linked to pain facilitation and its intriguing interactions with the calcitonin gene-related peptide system within the trigeminal network. Buckle up, because this is going to be an enlightening journey into the mechanisms of face and head pain. This slide shows how TRPA1 activation triggers the release of calcitonin gene-related peptide in the nervous system. We'll also dive into some antagonists of the TRPA1 receptor, specifically mugwort and rosemary. The idea here is that if we can block the opening of this channel, we can ultimately reduce the release and effects of calcitonin gene-related peptide. As we've discussed in our lecture, this has significant implications for the treatment and prevention of migraine. Our goal here is to minimize the pronociceptive effect of calcitonin gene-related peptide. When CGRP is released and binds to its receptors, it ramps up pain and sensitivity. So first we want to directly antagonize CGRP wherever possible. Second, as shown in this illustration, the TRPA1 channel plays a key role in facilitating the release of CGRP. By antagonizing the TRPA1 channel, we deliver a 1-2 punch. We not only block or reduce the release of CGRP, but also aim to directly impact the CGRP pathway. This dual approach is designed specifically for our headache patients. Let's look at a few studies that support this approach to headache management. The TRP-ankyrin-1 channel, abbreviated as TRPA1, has been identified as a critical component in various painful disease models. Recent scientific research indicates that TRPA1 channels found in the nerve terminals of nociceptors, specialized neurons that detect painful stimuli, significantly contribute to migraine mechanisms. What makes the TRPA1 particularly noteworthy is its remarkable activation profile. This channel responds to an unprecedented variety of irritant and pain-provoking substances, both from external sources and those produced within the body. When activated, TRPA1 triggers the release of calcitonin gene-related peptide, a neuropeptide known to promote migraine. Given these findings, TRPA1 is increasingly recognized as a major pathway contributing to migraine pathophysiology. This makes it an especially promising novel target for developing more effective treatments for both general pain conditions and migraine specifically. This information is based on research published by Bename, Fusi, Trevisan, and Gepetti in the British Journal of Pharmacology in May 2014. TRPA1, a member of the TRP family of cation channels, is involved in a plethora of processes including noxious cold and noxious pain sensations, inflammation, and the detection of irritant chemicals. Researchers have discovered that borneol inhibits TRPA1 mediated cationic currents in the low millimolar range in both heterologous expression systems and in neurons cultured from trigeminal ganglia. This finding has significant therapeutic implications. In TRPA1 channelopathies such as neuropathic pain and trigeminal neuralgia, Borneol, acting as an inhibitor of TRPA1, could potentially serve as a safe therapeutic combination option for treatment. This research was conducted by Shirkley, Schreiner, Hack, Werner, and Hatt, and was published in the Pakistan Journal of Pharmaceutical Sciences in July 2015. Neuropathic pain is notoriously difficult to treat and typically responds poorly to common analgesic medications. Researchers have discovered that borneol, a bicyclic monoterpene found in the essential oil of various plants, demonstrates remarkable anti-hyperalgesic effects in a mouse model of platinum-based chemotherapy-induced neuropathic pain. This effect occurs through blocking the transient receptor potential ankyrin-1 ATRPA1 channel, as demonstrated in both mechanical and cold stimulus tests. The findings indicate that borneol exhibits robust analgesic efficacy in neuropathic pain, specifically by blocking TRPA1 in the spinal cord. This suggests that borneol may be a useful analgesic compound for treating neuropathic pain conditions. This research was conducted by Zhu, Zhang, Zhou, Fang, and Ji, and was published in Neuroreport in February 2016. Artemisia is a plant widely used in traditional Mexican medicine for treating various painful complaints. Research has confirmed the effectiveness of essential oils extracted from Artemisia for attenuating neurogenic pain, as demonstrated using the hot plate test. Interestingly, the anti-nociceptive effects of these essential oils were blocked by naloxone, suggesting that their mechanism of action involves the opioid system. The study demonstrated significant pain-relieving effects that appear to be mediated through opioid pathways. Chemical analysis of the essential oils revealed that 18-Senel and borneol were among the major compounds present in the plant. This research connecting traditional use with scientific validation was conducted by Anya, Eugenio, Rivero Cruz, Bai, and Linares, and was published in the Journal of Ethnopharmacology in February 2016. Researchers examined extracts from the leaves of Japanese mugwort, using two different extraction methods to identify their volatile constituents. The first method employed was steam distillation under reduced pressure, followed by dichloromethane extraction, abbreviated as DOPRI. Analysis of the extract obtained through this method revealed that borneol was one of the major volatile constituents present. The second method utilized was simultaneous purging and extraction, abbreviated as SCSA. The extract obtained through this alternative technique contained two major volatile constituents, 18-Senel and borneol. This comparative analysis of extraction methods and their resulting chemical profiles was conducted by Umino, Hagi, Nakahara, Shoji, and Shibamoto, and was published in the Journal of Agricultural and Food Chemistry in August 2000. TRPM8 and TRPA1 are important thermosensitive receptors with different functions. TRPM8ED detects cool temperatures in response to menthol, while TRPA1 serves as a sensor of noxious cold temperatures. For analgesic development, an ideal compound would activate TRPM8 while simultaneously inhibiting TRPA1. Research has shown that 18-Senel inhibits human TRPA1 currents in a dose-dependent manner. This inhibition occurs regardless of whether the TRPA1 channels are activated by various agonists, including allyl, isothiocyanate, menthol, flufenamic acid, or octanol. In vivo sensory irritation tests have provided further evidence of 18-Senel's therapeutic potential. These tests demonstrated that 18-Senel confers an analgesic effect specifically on sensory irritation produced by tryptophan agonists, such as octanol and menthol. The research concludes that 18-Senel represents a rare natural antagonist of human TRPA1. Its documented analgesic and anti-inflammatory effects are likely attributable to this inhibition of TRPA1 channels. This research was conducted by Takeshi Fujita, Uchida Yamamoto, and Sawada Shimizu, and was published in Molecular Pain in November 2012. researchers conducted identification and quantification of the chemical constituents present in essential oil isolated from air-dried aerial parts of rosemary. This comprehensive analysis identified 29 different chemical compounds in rosemary essential oil. In these various constituents, 18-cineole was found to be one of the main components of the oil. The study went beyond chemical analysis to investigate potential therapeutic applications. When administered to test subjects, the rosemary essential oil significantly increased the latency time of animal response to heat-induced pain, indicating notable analgesic properties. This research on rosemary's pain-relieving potential was conducted by Raskovic, Milanovic, Pavlovic, and Milajesevic, and was published in the European Review for Medical and Pharmacological Sciences in January 2015. Here's a prime example of rosemary oil. It's super easy to find. We've already touched on some studies that highlight its effectiveness as a pain reliever, especially when it comes to neuropathic pain and migraines. In our office, we whip up a special gel that's super simple yet effective. It starts with a plain ultrasound coupling agent, and if you peek at the bottle, it looks like your typical gel container. We fill about 75 of it with the gel, and then we add a splash of green rosemary oil. We usually toss in 15 to 20 drops of that fragrant goodness. Now for the brown layer at the bottom, we get a bit crafty. We take mugwort capsules, pop them open, and place the contents in a coffee filter. Then we soak that filter in warm water. Just like steeping tea, once we've brewed our mugwort tea, we pour it into the bottle and give it a good shake. This concoction serves as a fantastic topical agent for pain relief. You can also apply it to acupuncture points, targeting the supraorbital nerve, infraorbital nerve, mental nerve, and suboccipital nerve. This helps anesthetize the terminal ends of the trigeminal ganglia. It works wonders, just a heads up. Be careful not to get it in the patient's eyes, as the rosemary can be a bit volatile. Also, the mugwort tincture might stain clothes, so handle with care. Give this a try. It really does the trick. Let's begin focusing on research findings regarding Sangre de Grado's effects on CGRPP pathways and its theoretical applications for migraine treatment. This traditional botanical medicine, also known as dragon's blood, demonstrates properties that may be particularly relevant to migraine therapy. Our key finding relates to CGRP, or calcitonin gene-related peptide, which is now recognized as central mediator in migraine pathophysiology. In preconstricted rat mesenteric arteries, we discovered that even highly diluted Sangre de Grado at a concentration of just 1 ton caused a statistically significant rightward shift in the CCRP dose-response curve. This means that in the presence of Sangre de Grado, higher concentrations of CRP were required to achieve the same vasodilatory effect. This pharmacological pattern indicates that Sangre de Grado functions as a CGRP antagonist. It may work by competing for receptor binding sites, modifying receptor sensitivity, or interfering with downstream signaling pathways. That's particularly remarkable is that this effect occurs at such extreme dilutions, suggesting potent activity of the active compounds. The relevance to migraine is substantial. CRP is released during migraine attacks, causing vasodilation of cerebral and meningeal blood vessels and neurogenic inflammation. These processes contribute to the characteristic pain and associated symptoms of migraine. The current revolution in migraine therapy has centered around medications that block CGRP activity, either the peptide itself or its receptor. The research suggests Sangre de Grado may offer a natural alternative to these synthetic CGRP antagonists known as gepants. Theoretically, Sangre de Grado could be developed for migraine in several ways. It might serve as a prophylactic treatment to prevent CGRP-mediated vasodilation before it occurs. Alternatively, it could be used as an acute intervention during migraine attacks. Its advantage over existing treatments may lie in its natural origin and its multi-mechanism approach, simultaneously addressing CGRP antagonism, neurogenic inflammation, and pain signaling. This comprehensive study showed that rhizomal ligostasi's volatile oil component could effectively treat headache through multiple mechanisms, including CGRP modulation and serotonin enhancement. The 2-FNU pill study demonstrated how traditional combination therapy could affect multiple pathways, simultaneously including CGRP modulation, neurotransmitter balance, and vascular function. Clinically speaking, you can use the herbal form of sequin lovage root, shown here on the left of the slide, in pill or tea form to modulate the release of calcitonin gene-related peptide. Now let's circle back to the sphenopalatine ganglion block. In the past, I've used Q-tips dipped in dragon's blood, gently inserting them through the nose to coat the sphenopalatine ganglion. This technique has proven to be very effective for headaches. Disclaimer, just remember, it's crucial you to feel confident. You are qualified and legally within your scope of practice before performing this procedure. On the next slide, you'll see a gentleman who was my very first patient many years ago. We utilized suboccipital nerve stimulation along with dragon's blood on Q-tips to modulate the sphenopalatine ganglion, and the results were truly remarkable. I've kept in touch with him, and he's enjoyed ongoing relief from his cluster headaches for nearly 30 years now.
I'm 43 years old right now, and I've had headaches since I was 18 years old. Pain starts right back here in the back of my head. It goes up along the side here, and it gets behind my eyeball. My eyeball feels like it's going to explode. Someone's got a knife in the side of my head, twisting it. Happens in the side of my face will like droop, either throw up or just crawl up in a ball and start crying. It would hurt so bad. I was told I have cluster headaches with touch of migraine. I went to see a neurologist when I first started getting these headaches, and he gave me pills. He says, "Here's some more pills, Frank. Try these out." I tried those pills out. A couple weeks later, I said, "Doctor, not working." He said, "Okay, here's some more pills for you. More pills, more pills." I had at least 20 different prescriptions sitting in my cupboard, and it just drove me crazy. They were treating the symptoms, not the problem. My life was affected immensely. I told my wife the other night, I said, if I wouldn't have seen Dr. Kugren, I would have probably committed suicide by now.
All right, let's tie this all together with a quick recap. We dove into the headache circuit and its relevance to nearly all primary headache disorders. We touched on Nardone's research, particularly the trigeminal cervical reflex and how the cervical spine connects with the fifth cranial nerve. Next, we explored head-forward posture, how to correct it and its link to different types of headaches. I shared the first rib adjustment, which is a real game changer. In my experience, nothing shifts posture faster than this adjustment on the first rib. He also discussed various neuromodulation techniques, including laser acupuncture, transcutaneous vagal nerve stimulation, direct stimulation of the trigeminal nerve's terminal ends, ear insufflation, and sphenopalatine ganglion modulation. Then we delved into the neurochemistry behind it all, highlighting the role of calcitonin gene-related peptide in headache physiopathology and the TRPA1, ion channels' connection to pain processing, and the release of calcitonin gene-related peptide. We wrapped up by discussing natural herbs and compounds that can help modulate both the calcitonin gene-related peptide pathway and the TRPA1 pathway. This gives you a solid toolkit for managing various primary headache disorders. I hope you enjoyed this lecture, and I look forward to seeing you in the next one. Thanks for attending.